All right, we're going to start our next session. Chris Gross from MUSC will be moderating this session. You've already seen Chris earlier today. Chris, it's all yours.
Thank you, Dr. Parekh. And again, another shout out to the Parekh Family Foundation for sponsoring this and all of the sponsors that you can see below us. So we're going to be talking about, we're trying to help you along with choosing the right implant for you. And to be honest with you, Danny is my partner here at the Medical University of South Carolina in Charleston. And we have debates all the time of what is the right implant for the right person. And it's a struggle because you work with an implant, you love it, then you see the outcome data and you hate it, or you don't like the way the instrumentation is, or patients just had certain postoperative complications that you have never seen before in a total ankle. So it's keep your mind open. The first talk we're going to have today is I'm simply going to be talking about some design considerations for total ankles. I'd like to thank Ariel Polanca for recording a session for us about mobile bearing implants, and I'll be playing her pre-recorded talk. Then we're going to have Danny talk about fixed bearing implants and why he chooses what he chooses, and finally Constantine, rounding it out with some excellent work he's done with showcasing why stemmed implants are better for certain patients than others. And if I step on any toes regarding what specific things you're talking about, I apologize. All right, so I've given this talk in a couple of iterations at a meeting, and I think I published it online. But what is the right total ankle implant to choose? And I don't have an answer for you. I can give you some guidance and let you choose for yourself. But we've really come a long ways from the 70s. So this is the Lord and Moreau total ankle replacement, which, if you can't notice, is just an inverted total hip. So I don't know how well these patients did, but I assume very, very poorly. So the first generation of total ankle designs, there's a lot of tibial and talar bone loss as the implants became loose. There's a lot of osteolysis. Wound complications, I don't think we've ever gotten that all together correctly. But with the amount of failures, we seem to learn every different generation. So in the second generation, there was porous metal back surfaces to help improve osseous integration. It's not just a plastic piece that you're cementing into the talus. And they found that these implants do better with improved stability by fusing the syndesmosis. So these implants have an inherent coronal plane instability that you have to correct. And so complications include the syndesmotic non-union, polywear, implant migration, and impingement are the major four. And then it brings us to the third generation of implant. Above there is a saltitolaris. Below that is the star, which Dr. Polanca will be discussing in greater detail. But they're trying to respect the amount of bone that you're taking off. So there's minimal bony resection. Different iterations of the star have come out in terms of the bony ingrowth. Same thing with the Hinnerman, and every generation improves the bony ingrowth. So they retain ligamentous support. There's a lot of anatomic balancing, so respect of varus valgus, doing your brochum when it's needed, doing a deltoid peel when it's needed. Refined implantation, just basically a more comprehensive surgical technique. But ankle replacements is a fun thing if you're into engineering. It's evolving all the time. So here's just an example of an implant, the Cadence with an anatomic tibial pace plate. But you can see a fibular sulcus there. And they've been toying around with a conical axis of rotation here because the talus is not exactly uniform, as you can see right here. So the small medial condyle the medial condyle is smaller than the lateral, so you have to take that into account. So you see when you build this into the implant itself, there's a conical axis of rotation here. The axis is centered on the ligaments, which we're preserving, whereas in some of these implants, you're really putting a lot of stress on the deltoids and the lateral ligaments. And so every generation is trying to improve the past. All right, so you can see here that the flexion extension movement it's conical, whereas on the left, you have your stemmed implant talus design versus the conical articular surface. Now, I'm not pushing for one or another, but it's just something to take into account. So with the 4th generation, we have our chamfered cuts. We're trying, again, not to have any anterior tibial cortical breaches like we saw in the Salto or the Star, in case that's, a place for synovial fluid to get trapped or go to and cause implant loosening. There's patient-specific instrumentation and highly costly polyethylene. This is an implant agnostic talk. I'm not going to push for one or another. I'm just going to leave it out in an unbiased position. So the good about the Infinity, it was the first to use PSI, so it really brought to market total ankles and allowed for its popularization, I would say. It has a low profile tibia. There's ingrowth capabilities on 3 sides, and the tibia nicely slots in. There is a chamfer design to the talus, and that again reduces the amount of bone that we're taking from the talus. So what are the bad things to take away from this? Unfortunately, it does allow bad surgeons that shouldn't be doing total ankles to have the confidence to do total ankles with the PSI. And there's some concern, and Constantine had a paper about this, about some of the radiolucencies. But the Infinity outcomes overall are quite good. The overcomplication rate was about 9% in a multi-center British study that was prospective, just a really well done study. And only 5 implants were revised. They did not look at the radiographic outcomes, however. Implant survivorship with Marie Penner, 97% at 35 months. So the systematic review basically shows that maybe a 6% revision rate at 24.5 months, which is fairly decent. And the revisions were performed due to aseptic loosening and subsidence. But it does have its mixed outcomes. In a study of 159 ankles, 7.4% had tibial lucency. And then in 2018, periprosthetic radiolucent lines were seen in 31% of the ankles, which is a concern. And I think because of this concern, they've moved to the Adaptus, which is the same iteration, except everything's 3D printed. So the 3D printed component is supposed to act as a scaffold for bony ingrowth. They use a highly crossing polyethylene at this point. The tibial implant design is still low profile, and when you are putting it in, you do feel that it's a lot more solid when you're implanting it. So the Cadence, it has great instrumentation, extremely quick to put in. So it's useful in patients where you have to do a lot of other work. And this is even without PSI. You saw earlier that it provided complete coverage of the resected tibia, allowed for a fibular sulcus. There's a conical axis of rotation for the talus that we showed earlier. There are biased polys, anterior, neutral, and posterior. But my philosophy is you should get it balanced the first time. There's no PSIs. There are a lot of tibial radiolucencies that you'll see in the literature. Early on, they had a posterior tibial fracture, but that was just a matter of changing technique, and that went away. So there are a few studies for Cadence outcomes. 32 ankles, 24 months. Survivorship is 94%. So 58 ankles, 43 at 2 years. About 20% of these underwent an additional procedure. But what we're seeing is as the implant keeps on going, the fibrous ingrowth, the tibial component, may not be exactly perfect. So in a study of 69 patients, 26% of them had fibrous ingrowth, which is concerning for me because it looks like it was well aligned, but if the implant is not integrating, then that's a concern for the tibial component. And then you can see this here, and if the patient's asymptomatic, kind of wait and see, but I don't like to see those in any of my x-rays. And it's not just that implant, it's a lot of them. Here we have restored Kinos, which allows anatomic motion in 3 planes. has PSI. They have a lot of enhanced coronal plane stability with the design here. The bad is that they've already redesigned their tibia. They're redesigning, may be redesigning their talus. So in the original versions, there was no porous ingrowth of the tibial component, and there may be just too slop for the stability for the implant, which is why they may have to redesign other portions of it. So there's no outcomes to date. So the Vantage, it was created from CT scans of normal and arthritic ankles, and a fibular notch that allowed for increased coverage. Taylor component had a rounding device, but we're still waiting on large outcome data. We know that it exists. We just haven't seen it quite yet published. The locking clip can disengage, which is not fun to have to tell a patient you have to watch it or leave it, watch it and leave it, or take it back to the operating room. And they're currently, they recently had FDA approval for new tibial sided components. So short outcome studies, not too many patients, but it basically shows reasonable survivorship. We have our laterally placed Zimmer ankle design. It's allowed to mimic the natural curvature of the tibia and talus. It's really closest to the center of axis rotation of any other implant. But again, the bad is implanting it. So you have to cut the fibula, you have to take down the ATFL, you have to, obviously fix it. Now, the people that are very good at it are very good at it, but the people that it's just a high barrier to entry. And there's obviously this external jig, which is not fun to deal with. The survivorship is decent, 97% at 3 years, 26-month follow-up, 93%. But what's interesting is that a lot of these patients will need secondary procedures. You can see here in 30 patients at 30 months, 10% had radiolucent lines, but there are a lot of major complications requiring surgery. So that resulted in 23% of patients that needed to go back to the operating room. And what they found is that it's really hard to tell based on how you're doing this implant of what your alignment is. So a lot of these cases were because of misjudgment of hindfoot alignment, which is simple to do when it is a straight anterior approach. Another implant on the market, there's a surgeon portal for planning. The talus has a double radius of curvature. This is the quantum into bones. I tried to find a surgical technique online, but I still haven't been able to. So I'm not really sure about the non-PSI technique, but none to date. The Paragon Apex 3D, it's 3D printed low profile tibia. So this, is kind of the other end of the spectrum of low profile tibia. The arc is shaped, which may present some issues with flat tops in the past, so allows for better osseointegration and more surface area for integration, but there's just no long-term data yet, and there's not a precedent for an arc tibia to date. The instrumentation is improving. The Hinterman is mobile bearing, and Dr. Palanca is going to be talking about the STAR, so I'm just going to hold off on that. There's a tibial shield that may disperse some of the stress shielding and also allow for more, just to help biomechanically for the ankle itself with ligamentous issues. The anatomic talus is based on CT geometry. There's a lot of data behind it, like a lot of very good data. There was a recent FDA warning with Dr. Polanco we'll discuss. The instrumentation is designed for Dr. Hinterman, so it works for him, but they're working on improving the instrumentation. And you have to remember with mobile bearing implants, there's no coronal plane stability. So if they have a syndesmotic injury in the past or present, you cannot use this implant. So it results in 15 and 20 years, just a really great survival rate, 82% at 15 years, and aseptic loosening was the most common reason for revision. So we're going to talk about stem implants later, so I'm going to hold off right now. And I'm going to turn the screen to Dr. Polanca, who's recorded this talk for us.
Hi, my name is Ariel Polanca. I'm talking about the mobile bearing side of the total ankle replacement story.
And I just want to confirm, do you guys hear it as well?
Yes.
Love it. Thank you.
I just want to say thank you to Dr. Parekh for organizing this, and thank you to all the participants. I'm sorry I can't be there in real time. I did get recruited for trauma call, so I wish I was there. So what's the story with the 3-piece or the mobile bearing total ankle replacement? I'm not going to be too pedantic. There's really just one difference, and there's no locking mechanism for the polyethylene piece into the tibial tray. I'm going to mainly be talking about the STAR total ankle replacement simply because it's been the only mobile bearing prosthesis approved for use in the United States up until about a year ago. So most of my talk will be based on the STAR, but we will be discussing the Hinterman a little bit more at the end. So why? What would be the benefits? Why would anyone select a mobile bearing prosthesis versus a fixed bearing prosthesis? Well, for a few reasons. First and foremost, the mobile bearing minimizes the bone implant rotational stress. So rather than seeing the stress from where the bone communicates to the prosthesis, the stress is translated through the polyethylene. This also minimizes the rotational shear stresses at the interface. It also reduces micromotion, particularly immediately post-op, compared to the 2-piece ankles. And when you have reduced micromotion, this allows more opportunity for bone on-growth for the prosthesis. Also, even imperfectly placed implants can find their happy place because the metal is not constrained by the placement of the plastic piece. So is there really motion? Yes, but not a lot. So you have a sagittal range of motion of approximately 23 degrees, axial motion for about 6 degrees, and AP translation just about 1 degree. But there isn't any relationship between the motion of the polyethylene and actually the ankle joint range of motion. So it shouldn't be thought that the more motion of the polyethylene will contribute anything to more motion of the tibio-talar joint. So there's quite a bit of data looking at the STAR metal component survivorship, anywhere between 9 to 19 years, showing upwards of 90% survivorship in some cases. I performed a study with Dr. Mann back in 2018, showing at least 15-year follow-up with a 73% survivorship at up to 17 years. I'm going to talk about that study a little bit more in depth. So back in 2011, Dr. Jeff Mann and Dr. Roger Mann performed a study showing a 90% survivorship of the metal components at 9-year follow-up, and then took that cohort to 15-year follow-up. And the study goals were to determine the metal component survivorship, assess patient functionality and satisfaction, also outline complications and need for secondary procedure. So there's originally 84 ankles and 80 patients in the pre-FDA study. At the 15-year follow-up, only 24 were available, so we did lose quite a bit to follow-up. A lot of different reasons, mainly death, but also just lack of accessibility. So this was a survivorship plot showing a 73% survivorship at the 17-year mark. So of those 24 that we were able to contact and follow up with, there was an average of a 15.7-year follow-up. Average age was 74 years old. Of those, 87% had medical component retention, so they did not need to have a revision total ankle procedure. There were 3 failures, and 1 was for talar subsidence that needed to be revised, and 2 were for aseptic loosening. And these all occurred after the 11-year mark. So in terms of the AOFAS ankle hindfoot score, compared to patients from preoperatively to postoperatively at 15 years, there's a significant increase in the AOFAS score. So if you look at the average AOFAS score at 9 years, it was 78.6. So you do see a decrease in the AOFAS score between the 9-year mark and the 15-year mark, just slightly. And if you separate those between the pain component and the function component, we see that the pain component decreased at about 3.2 points, or the function component decreased by 5.3 points. And as patients get older, it makes sense that they may have slightly decreased function and slightly increased pain. So looking at radiographic follow-up, again, we talked about the 3 failures, 2 for aseptic loosening and 1 for talar subsidence. 3 other ones had talar subsidence, but minimally that didn't need to be realized. and there was never any migration of the tibial tray. There was one persistent coronal plate deformity, 14.3% of adjacent joint arthritis, one being symptomatic requiring infusion, 28.6% risk of osteolysis, and a 61.9% rate of heterotopic ossification. And sometimes that was really significant. About half needed subsequent procedures, and 2 needed 2 subsequent procedures. Most of these happened later, so between that 19 and 16-year mark, at least 3/4. And we saw 3 polyethylene fractures, and these occurred at the average of 12 years postoperatively. So conclusions from this study were that the STAR ankles that survived to 9 years were likely to also survive to 15 years. The patients did well overall with minimal depreciation in the pain and function AOFAS scores. That adjacent joint arthritis and polyethylene fracture was rare, even up to 16 years, but that subsequent procedures were common. And this is just an example. This is an X-ray taken of one of the first STAR total ankle replacements that was performed 22 years ago. There's other studies as well. This was a good study done out of Denmark. This is looking again to up to 17-year follow-up at a large cohort of ankles from a single center. And they looked at the 10 as well as the 15-year medical component survivorship, and they found it to be greater than 98%, even at 15 years. And to return to the polyethylene, they looked at a 74% survivorship of the polyethylene at 15 years. Another study looking at fixed versus mobile bearing total ankles in a meta-analysis concluded that there was no difference in the survival rates between both groups, though of course, as all studies, we will mention that longer follow-up and more studies are needed. In looking at the study out of Duke, it was a prospective study looking at the mobile bearing versus the fixed bearing total ankle replacements. This shows that the outcomes were favorable with both designs. There was not a significant difference in clinical improvement between the fixed bearing and the mobile bearing. However, there was a higher incidence of cyst formation in the talus with the mobile bearing as opposed to the fixed bearing. There has not been further studies done on this, but something that needs further investigation. So current controversies are with the H3 total ankle that's been brought to the US market recently. It was an implant that had quite good survivorship and follow-up in Europe. But actually just recently, in February, the FDA did put out a notice citing a higher than expected risk of the device failure since it's been brought to the United States. And I think this is, I wish I could be there for this discussion because I think this would be really interesting to discuss with all of you. Thoughts behind it. Now, of course, the Hinchman was mainly being used by one surgeon at a single center, and that's where most of the research is provided from. So it could simply be that the newer surgeons aren't as experienced or don't know the exact technique that Dr. Hinchman was using. I personally think that the Hinchman doesn't have really robust fixation into the tibia. So my thoughts are, is it possible that there's micromotion between the tibia, not allowing for on-growth in that early post-op period? I don't know, I don't have much experience with this implant, but since we're talking about mobile bearing, I think it's definitely poignant to bring out that this is something that is very controversial at this time, especially with the new implant. So in conclusion, studies show comparable clinical outcomes with mobile bearing versus the fixed bearing TARs. Also, there's promising long-term survivorship for mobile bearing TARs. Also, we need more long-term studies, particularly as these 4th generation 2-piece systems have been used for longer periods of time to compare the new implants and really investigate the survivorship of both the fixed bearing and the mobile bearing TARs. So thank you. Thank you so much. Sorry I could not be there in real time, but I will definitely be popping in anytime the ER isn't calling me. And thank you once again to Dr. Parekh and all the participants and all the moderators for participating in this awesome course. I hope you guys have a wonderful 24 hours.
Thank you, Ariel. Danny, you're up.
Awesome. So as Chris mentioned, my name is Danny Scott. I'm also at the Medical University of South Carolina. I'd also like to thank Dr. Parekh and the Parekh Family Foundation for putting this on, and to all the sponsors. So certainly this talk will be about why I choose fixed bearing, and we'll be talking primarily about fourth generation total ankles, a little bit of third generation. I'll try to stay out of the in bone for the most part to let Constantine have his part. These are my disclosures. This can also be found on the Academy website or through the AFAS. So where are we going in the next 10 to 15 minutes here? So Chris has already done some of this, but I want to highlight some of the problems that we've had historically with total ankle and what we're trying to do with the newer generation of implants, or what things we're trying to avoid that our predecessors have fallen into. We'll briefly look at some of the data and highlight, I think, some of the studies that support fixed bearing, and especially some of the newer generation ones. We'll talk about a few of the benefits of the current generation of fixed bearing offerings, especially compared to some of the mobile bearing ones, and then a little bit about why I choose fixed bearing. So to start with, this is a study by Barg back in 2015 that basically looked at total ankles and comparing them to hips and knees, right? And we all know that total ankle, we don't have as much data. Our implants are not probably quite as good as our hip and knee replacement colleagues. But what problems are we dealing with that they're not dealing with, or in different rates, right? And so you can see these are sort of failure rates here, or reasons for these ankles to fail. And the thing I want to point out here is aseptic loosening, right? That's the biggest reason when you look at most series that a total ankle will fail. And so when we're designing or selecting a prosthesis, that's probably one of the biggest things we want to be thinking about, is avoiding that aseptic loosening. Certainly, we know that instability can happen as well. We certainly know there's septic loosenings, and obviously we all want to prevent infections, but there's only so much an implant may or may not be able to do about that. And then we have some other things that are a little bit more rare as we sort of go down the list here. So let's look at historically, what have we dealt with, right? So again, loosening has been a big issue, especially tibial sided. When we look at a lot of the second generation implants, this was a big reason for failure. You can see on the right here, trying to get a syndesmotic fusion was maybe not the best way to design an implant, but certainly a lot of those implants were failures. And so that's something that both the third and fourth generation have sought to address with our newer total ankles. Instability has been an issue as well, as we highlighted a couple slides ago. I would certainly point out, as someone who has some experience with mobile bearings, that is definitely something you can see with these, having heard both Hinterman talk about his implant. It is interesting to see some of the medial unlateral instability, or even syndesmotic instability that you can get with that implant. That is maybe a different mode than you might see with a fixed bearing. Certainly with some of the series of stars, we've seen instability being a big reason for failure, or coronal plane failure, especially if you look at the work of Lowy and the folks out of Tampa. That was the biggest reason for failure in their series of stars, along with Art Walling and Sanders and all those guys. So this is certainly something that happens with mobile bearings enough to be a concern. So in contrast to the mobile bearing, when we look at fixed bearing, what does the data say? What would push us to say, hey, maybe this is where we should go? The Salto Tularis of the fixed bearing implants is certainly one that has some pretty robust data. This is obviously a study out of Duke back in FAI from 2017. Retrospective review of 72 Saltos. Obviously, it's a little bit of a retro pro study as well, because they did have some PROs I didn't put on the slide. They have a mean 6.7-year follow-up. So for most of our fixed bearing total ankles, that's pretty doggone good. You can see their range there is pretty wide, 5 to 9.5 years, but a minimum of 5-year follow-up, which is hard to do. 95% survivorship, right? This is very strong for almost any of our implants. Only a 19% rate of reoperation. So I would say this is one of the studies that when I look at, say, wow, this is something that may hold up. Another Salto study, so you can see Constantine is one of the many authors here. Obviously, this is out of HSS, and they've done a great job as well of putting out a ton of great total ankle data. This is an FAI in 2020. So they had 85 Saltos, again, a mean of 7.1-year follow-up with a range of 5 to 12, so similar, but even a little better than the folks out of Duke. Again, very good survivorship here, right? When you're looking at 97%, over 90% survivorship at 7 years, this is stronger than a lot of other implants on the market. And again, only 21% reoperation rate. So again, this is, I think, one of the third generation fixed bearing implants that when you start to look at the data, you say, wow, this thing, at least at medium term, is holding up really well and maybe something that either we want to emulate or continue to use. So when we look at some of the fourth generation ones, so one of the downside with our fourth generation total ankle implants, as Chris sort of talked about, is we don't have that much long-term data on these implants, right? A lot of the studies are only 2 years out. This is one of the longest term studies that I'm aware of on the Infinity. So this is a retrospective review of multiple surgeons out of Latin America. You can see the authors on the top right there. This was in Foot and Ankle Specialists just last year. They had a mean of 4-year follow-up, which is pretty strong. They did not report their range, at least not anywhere that I could find in the paper. But again, a mean of 4 years, at least as far as I'm aware of, is the longest term follow-up on Infinity. They had 100% survivorship, which anytime you have 100% of anything, that's very, very impressive. And only 4.2% rate of reoperation. I wish a lot of my implants could have 100% survivorship, but still, I think for a fourth generation implant that we know already has some issues with radiolucency, as both Constantine has published on and as Chris has talked about, I think it's very impressive to see robust survivorship numbers starting to get closer to medium term. And I think lends credence to the fact that maybe these fixed bearing implants are onto something. When we look at some of the other fixed bearings, as Chris talked about, so the Zimmer implant with the lateral approach is another one that's been around now for sort of a medium period of time. This study by Federico and some of the other folks is the longest term study I'm aware of. This is multiple authors, so this is not, or multiple surgeons, so this is not just Federico's data. This was in the Bone and Joint Journal in 2022. So this is a retrospective review of 98 Zimmers, right? So a pretty good sized cohort. They had a mean 89-month follow-up, so really getting into sort of medium-term follow-up for a third generation implant is, I think, is pretty strong. You can see their range there was pretty good, 60 to 90 months. And again, very strong survivorship, 97.7% and only 11.2 rate of reoperation. This certainly contrasts some of the Canadian data as well as the data that Chris has shown with higher reoperation rates with the Zimmer. I know certainly with some of the Canadian data, one of the things that was driving their high rate of reoperations was how they fixated the fibula. You can see, at least from this picture, there's some people that are doing it, at least in this diagram, with screws, and so maybe there's something about the way you fixate the fibula or way you do other things that might drive that reoperation rate. But regardless, I think this is one of the papers that at medium term is showing pretty impressive survivorship of, again, some of these third generation fixed bearing implants, and I think offers us hope that maybe these things will outperform some of the predecessors. This is some data of Chris and I's. This is a poster that we presented at the Academy this past year. So we went and systemically reviewed all the third and fourth generation total ankles in the literature. So it was a total of 6,400 patients. This was all minimum 2-year follow-up. And then we had sort of, you can see here, we broke them into fixed and mobile bearing. When we did that, you can see obviously the follow-up was longer in the mobile bearing, which is not a surprise, right? Because you've got both the STAR and the H3, which have been around a much longer time than a lot of the third and fourth generation implants. However, we did do a multivariate analysis to try to control for that, because we all understand that in general, as follow-up gets longer, survivorship will go down. However, even when you do a multivariate analysis to control for length of follow-up, we actually saw higher metal component survival rates with fixed bearing as opposed to mobile bearing, right? And those numbers are pretty different, right? 96% metal component survival versus 87%, or just about 88%, even when controlling for length of follow-up. So this is one of the things, along with other studies, that are starting to say maybe there's something better about fixed bearing. Even the study that Ariel showed, I would highlight, if you're getting more cyst around an implant, as we saw from that study from Europe, maybe that could be a problem. When we look at the reoperation rate, no statistically significant difference here. When we look at the revision rate, no statistically significant difference. But again, a difference in metal component survival, which is, I think, concerning to say the least if you're using mobile bearing. When we talk about fixed bearings, right? So one thing is we have lots and lots of options on the market. I've sort of broken these down into a couple different ones. So on the bottom left, and Chris went over almost all of these, we have the Vilex. So I'll point out they have both an H2 and an H3. So the H3 is their mobile bearing, their H2 is their fixed bearing. Both are available in this country now. So certainly that's a third generation implant. There's not that much data on the fixed bearing version, but it does exist. Certainly we have the Salto, which as I've just shown has a lot of good data for it, at least at medium-term survivorship. So I think this is, of our fixed bearing implants, one of the ones with the best data. On the left side of the screen, I've grouped together sort of the older current fixed bearing offerings. So this is the Cadence, the Infinity, and the Zimmer. All of these have studies, as Chris pointed out, that have at least 2-year follow-up. As I've just shown you with the Infinity and with the Zimmer, we're getting closer to 4 and 5-year data there. And so at least if you want to pick a fixed bearing implant that has some robust data, at least at early to mid follow-up, all 3 of these implants at least have some data that supports their use. On the right side, we have sort of the newest offerings, right? So the sort of top right one would be our the implant that Chris was talking about and we're all very familiar with from Exactech. Then we've got the Paragon implant, the Intubones, and then the Kinos. All of these 4 on the right really have very limited data. As Chris pointed out, there is one study on the Exactech implant, but it doesn't even have 2-year follow-up. So I would argue all these are in a little bit of a data-free zone. However, they all have at least some ability to have PSI with, which I think is a very nice option, as well as, of course, the Infinity. So when we look at these implants, also there's a lot of variability and constraint. And so that's one thing that I think is interesting about some of these fixed bearing offerings, right? So we all know mobile bearing is different, right? Those are the 3-piece ones that Ariel just talked about. Then there's the implants that are more highly constrained, and I would put sort of the middle ones here as more highly constrained. Again, I'll sort of leave the InBone off for now, since Constantine's about to cover that, but both the Infinity and the Intubones ones appear to have more constraint than do some of these semi-constrained options on the right. And I think it'll be very interesting to see as the literature goes on, is there a difference in the level of constraint and the outcomes with these implants? But unfortunately, there's just so much data, right? There's so many implants right now that we just don't have data on. But I think the idea that you might have a little bit of play in a constraint in a fixed bearing implant certainly may be better. Though again, we'll have to see what the data shows. I think one of the big benefits of the current offering, especially of the 4th generation's implants, is their instrumentation. The instrumentation for multiple of these prostheses is really well done. On the left, we have the Infinity. Whether you're using Prophecy and their custom preoperative planning software or not, I think their instrumentation is quite streamlined and certainly makes it easy either if you're by yourself or if you're someone who doesn't do a lot of total ankles. It's a lot easier to use this instrumentation than some of the others. This is the Exactech instrumentation in the center. I do think they've done a very good job of designing, especially the tibial-sided stuff that they have. Their tailor prep can be sometimes a little bit more involved than you might want, but they have a lot of nice instrumentation in their sets that makes things pretty easy, and especially compared to some of the 3rd generation implants, I do think the instrumentation makes implementation more reproducible. Certainly makes it easier to train younger surgeons for those that are teaching residents or fellows or other people. And as Chris pointed out, the Cadence has, at least to me, probably the easiest instrumentation as far as a non-PSI implant on the market. It's based off some of the Hinterman instrumentation, but really took it to the next level. And I think all 3 of these implants, as well as some of the others, have very easy to use instrumentation, especially if you're more familiar with the Star or the Salto. And having easy instrumentation probably makes the surgery a little more reproducible, and certainly I think makes it a little bit easier on the surgeon. I think that segues nicely again into the patient-specific instrumentation. There is data out there that use of PSI, at least in the Infinity, saves about 30 minutes per case. So if you want to get your case done as expeditiously as possible, PSI very well can save you time. This is Paragon's version on the left, and you can see Infinity or Wright Medical's version on the right. Obviously in the center here, we have some of Wright's software, which is probably one of the most robust on the market. But regardless, it can be very helpful to get to think through a case ahead of time, sort of look at things in 3 dimensions, think about where you want to line up your implant exactly, and have instrumentation help you in the operating room to sort of make your cuts and try to do them as reproducibly as possible. And again, I think especially if you're a surgeon that maybe is not as high volume with an ankle replacement, maybe only does a couple a year, I absolutely think that PSI instrumentation can help you do that case more efficiently, or especially if you're by yourself. I think PSI can make things much, much easier. And most of the fixed bearing 4th generation ones on the implant have this as an option. Okay, so with all that, how do I put this together? How do I wrap this up? Why am I going fixed bearing? So for me, I love the streamlined instrumentation. I really think it makes the case go faster. I think it makes the case go more reproducibly the way that I want. And I just feel like I'm able to achieve my goals of surgery more consistently. I do think as far as teaching trainees, so I'm at an academic medical center, we have residents, we have a fellowship here. I think it is much easier to teach the trainees on some of this newer instrumentation, and especially on some of the PSI, and to be able to have the 3rd or 4th year resident coming into the case who hasn't seen very many total ankles be able to execute the case, as opposed to using some of the instrumentation, for example, for Star or Salto. I do think ligament balancing can be a little bit easier with a fixed bearing. Obviously, you do have more constraint with many of the implants, but I've found it sometimes easier to balance things when you've got that extra support. Certainly, I have a little bit less fear of postoperative instability. I've certainly seen some radiographs of Stars and the H3s that make me feel a little queasy, and I don't tend to see that as much with the fixed bearing, and that makes me feel better. And I think the data is very strong for the fixed bearing implants, right? Especially if you look at the 3rd generation implants, they tend to have quite good data, and we certainly need a lot more data on the 4th generation, but I think it makes sense intuitively why you would go with a fixed bearing, and the fact that there is a fair amount of data that supports them. So what do I want you guys to take away from this talk? So fixed bearing has robust data, especially for the 3rd generation. We need more on the 4th. You have a ton of fixed bearing implants on the market. In general, most of the instrumentation for these is very, very good and can help you achieve your goals of surgery more reproducibly, and it's probably a little bit easier to learn than some of the other systems. With that, these are my references, and thank you all so much.
Danny, thank you so much for that awesome talk. Constantine, you're up next about fixed bearing.
Well, thanks for having me on this, and I'll kind of give you a little bit of my personal journey through this and make a case for stemmed implants. These are my disclosures. So when I first started in practice, this is over a decade ago, and I say that because that sounds longer than 11 years, but these were the implants that I used in practice. These were the implants that were largely available, and had good initial success, but as Chris mentioned, with time, you start to see some problems, and I started noticing the cysts around the keel of the saltotalaris. And usually if you see a cyst on an x-ray, it's going to look bigger on a CAT scan, and it's going to look more bigger in real life. So I was bone grafting some of these cysts. Here, similarly with the Star, you can see a cyst around the barrels that I eventually had to go back and bone graft. I actually bone grafted the anterior cyst, and then a few years later had to go back and bone graft the posterior cyst, but the implant's still in. So it was believed at the time that fluid would get into the bone because of the anterior cortical windows, and the fluid with the polyethylene would create that inflammatory response in the osteolysis. And so when implants came out without violating that anterior cortex, that was appealing. And some of this has already been reviewed by you guys who have given great talks, but I'll sort of give you my experience. So I thought, well, this would be a good one to try. Preserves the anterior cortex of the tibia. It's low profile, minimizes talar resection. Seems like a great idea, but again, there's always follow-up that you have to manage and deal with. And you can see here a case of anterior subsidence in a seemingly well-aligned ankle. And we looked this up, and we published our data where we had about an 8% incidence of tibial subsidence at short-term follow-up. This was just about 2 years. And as we know from total ankles, not all implants that subside end up going on to revision. So it's a little tricky when you don't have radiographic follow-up, because sometimes these will subside, but patients will still be doing reasonably well, that they don't have to, or they don't want to have another operation. And we also saw the lucencies, and it's unclear the clinical significance of lucencies. We have a study that we recently submitted for presentation led by Liz Cody on lucencies, and more to come on that. But certainly, if a third of your cases have periprosthetic lucency, that's a little bit concerning. So then this implant came out. It had larger coated pegs, broader coverage on the tibia. It was a little bit less constrained, still minimal bone resection on the talus. So seemed like a good idea. Let's try that one. And I did a number of cases, and we published our results on this implant. This is over 2 years, but not quite 3 years. And we had about a 94% survivorship. So yeah, 94% is pretty good, but that's 6% of patients that aren't making it past year 3. So that's not insignificant. And you can see here, we still had about a third of patients with periprosthetic lucencies. And you can see there an example. So still unclear what the right choice is. Where are we going wrong? Why are we seeing this in these implants versus others? And so then we did this study, and this has been a study that's been done by others as well, looking at the bone density. Bone density is not bone quality, but it gives us a sense of what we have to work with. And we looked at bone density at different levels above the plafond or below the joint on the talus at different millimeter increments, and we compared arthritic to non-arthritic. And as you can imagine, when patients have arthritis, they have subchondral sclerosis, so the bone is actually more dense than in a non-arthritic ankle. And then when you compare each millimeter to the other, so as you go up farther away from the joint, the bone gets significantly less dense. And this is true from 6 to 7, 7 to 8, 8 to 9. And a lot of these newer implants, with the goal of minimizing resection on the talus and having sufficient thickness in the polyethylene, we're cutting the bone pretty high up on the tibia, really 9 to 10, in some cases more than 10. And so we're putting lower profile implants on bone that is less dense. And so we really came to the conclusion that every millimeter counts. So then this other implant came out, and it had less resection on both sides, both the tibia and the talus. So you think, all right, well, maybe this is the solution, right? Maybe we got this figured out. So it has some vertical pegs, and that's good because it matches the axial loading on the tibia, resurfaces the talus, so we're still minimizing bone resection. That seems like a great idea. And we published our results, and this is a recent publication in the Bone and Joint Journal. And we published on 171 ankles at almost 3-year follow-up. And we have 94% success, which is good, but not great, which is similar to the other studies that we published. And we have 20% peri-implant lucency, but I would argue 20 and 30%, they're both high numbers. They're so they're different, but they're not really different. So maybe this isn't quite the solution either. And so then we did this study, and we looked at, and this has been updated, and it's electronically available, published for JBJS, so it's in press. And we said, well, maybe if we choose different implants, maybe if we're more thoughtful about how we choose implants, maybe we can reduce the risk of early mechanical failure. And so what we did is we looked at 731 patients at early follow-up, and we noted 4.5% incidence of mechanical failure. And then we looked at both tibia and talus. And age, sex, deformity was not associated with failure. Okay, and of course, this is assuming you correct the deformity, but deformity was not associated with failure. Similar to other studies, hindfoot fusion was an independent risk factor for failure, almost threefold. So again, when the hindfoot's fused, the mechanics in the ankle are different. And we have to respect that. We've all had cases where we've gotten away with it and it's been successful. And you're always tempted to do it, but it stands true. And I think when multiple studies at different centers show the same thing, we have to start to accept it. We also found that for every 10 kilograms of body weight the odds of the tibial sided failure increased. So even though many studies show that BMI doesn't matter, it may be really body weight. And it may be that our studies aren't large enough to show that BMI and or body weight matter. But at least in this case, we did see that weight was significant. And then when we assessed implants with a stem or a keel, so more fixation on the tibial side, well, that lowered the odds of tibial failure by 95%. Not 100, but certainly decreased the risk of failure, early mechanical failure on the tibial side. So here's a varus ankle, significant deformity. Here's the hindfoot alignment view showing significant alignment or significant varus alignment in the hindfoot. So here you have a stemmed implant, balancing the ligaments, releasing the deltoid, repairing the lateral ligaments. A Malurba lateralizing calcaneal osteotomy, and you know, you can certainly do a lateralizing calcaneal osteotomy in many different ways, and sometimes I do it minimally invasive. I still think a Malurba probably gets you the best correction when needed. And a dorsiflexion osteotomy of the first metatarsal. And here you see the hindfoot alignment view before, and here you see the hindfoot alignment view after. And so that makes you feel good. You think, all right, I got this, I can do it. And here's a valgus ankle, valgus at the tibio-talar joint. Here's the lateral valgus in the hindfoot. And you look at the CT scan and you see a big cyst. And you say, all right, well, I can fix this. I can do this. I'm going to use this stemmed implant. I'm going to resect bone. I'm going to build up my stem up into the tibial side. In this case, I did a fibular lengthening osteotomy, medializing calcaneal osteotomy, cuneiform osteotomy. And we're going to improve our hindfoot alignment view. I won't say it's perfect, but it's better. And so we looked at our end bones, and this is a minimum 5-year study that we did. This was a small group of patients. It's about 51 ankles. But at minimum 5-year, average was 6.5. We had a 98% success rate with a stemmed implant. So you say, well, then I've got this all figured out, right? Stemmed implants guarantee success. And we all know that's not true. So this is a case from this week that I did, and I thought I would show it to you because just because you go through the trouble of putting in a stem doesn't mean it's going to be stable. So now this is a little bit of a different case. It's a revision, but I've had this happen to me in primary cases as well. And I'm sure those of you that use a stem a lot have seen it happen as well. So here's a case of an ankle. This patient came to me with pain. I can't remember where she had the initial surgery, but it wasn't that long. Let's say it was, I can't remember now. Let's say it was 5 to 10 years out, something like that. And so my first reaction is, well, we need a CT scan. I need to see what's going on with this implant. So I get a CAT scan. So here's a representative image. This is a weight-bearing CT. And you see there that the talar component is subsided. It's translated anteriorly. And I'm thinking, all right, well, I need to do a revision. Can I save the talus? Maybe, maybe not. Probably not. She's a little bit older. And so I'm preparing for my revision. And I must admit, I didn't really pay attention to this until yesterday when I put this talk together. But I didn't really look at the tibia, right? And you can see there that there's not a lot of bone there, right? The cortices are thickened, but centrally the tibia doesn't look so great. So I take the ankle out. That was easy enough. I cut out the tibial component using a reciprocating saw and an osteotome, and the talus came out easily. And I'm going to line up my ankle for my stemmed implant. So I get my alignment guide, feeling good about that. Check it on the lateral, feeling good about that. And I get my drill up. All right, it's not perfect. We've all had that where for some reason the drill doesn't perfectly follow the alignment arm, but you say, well, I can work with that. It's not too bad. So I make my cut and I get a nice flat surface, and I'm going to start putting my stem in. So usually I have the C-arm in a lateral when I'm doing this. And here you can see I'm building up my stem, and I'm thinking, you know, I'm going to put some extra segments in to get some stability. Seems like a good idea. Why not? And I get this feeling of, well, maybe this thing is not going to be so stable coronally. So let me check my AP. So I check my AP. You see my hand there. It's in the way, but the stem looks pretty good. So I'm feeling confident. I put the final, the base segment in. I impact it, and I get this, right? So you got a stem that's kind of windshield wipering in the distal tibia. It's going to abut the medial cortex. So what do? Well, I'll tell you, the answer is not to leave it, because you're not going to sleep that night. You're going to be miserable when the patient comes in for follow-up and they have pain there. You're going to end up plating the distal tibia, and that's not going to work. So I had to take the stem out, upsize the stem, and put a blocking screw in. And I had to cement the base plate. So I've cemented the base plate. The stem is not cemented. The screw is holding the stem from tipping. And I can go on and finish the case. Here's the lateral. And again, do the total talus and fixate it to the calcaneus. Put a prophylactic screw. Obviously get that piece of cement out before you put your poly in. Prophylactic screw in the medial malleolus, and we'll see how she does. She is 3 days post-op. So in summary, stemmed implants can decrease early mechanical failure, particularly in the tibial side. Initial stability is critical, but it comes at a price. We're taking away more bone for these implants. In challenging cases or revisions, even stems can be insufficient, so consider hybrid fixation. Thank you.
Hey guys, great session. Hey, we got to wrap up, but Constantine, I've had that happen before, and one of the things I've done is I've impaction grafted the hole that you created in the canal, and then I've re-drilled a new canal, and that's worked as well. So you don't have to put the screw down. So that's an option as well.
Yeah, that's a great point. Yeah.
But great case, guys. Thank you for the discussion. Appreciate your participation.